Chapter 45, Pediatric GU Dysfunctions. So when we're talking about genitourinary dysfunctions, the physical exam and history are going to be essential in determining when this first started and helping guide our diagnostic eval. Diagnostic evaluation is typically going to involve labs, so blood work such as renal panel, urinalysis, and then radiology tests to examine the kidneys. And here's a brief little anatomy review. This should look familiar from your A&P. So the incidence and type of symptoms varies with age, and sometimes symptoms are more significant at a certain age than others. For instance, a child who suddenly starts having significant bedwetting at 8 years old is a lot different than bedwetting in a 3 or 4 year old child who is just freshly potty trained. Sometimes this has to do with the presence of malformations that were not detected previously in a diapered child. So as far as our lab tests, our renal panel is going to be a BUN, creatinine, and glomerular filtration rate, and then urinalysis. Our typical imaging studies of the renal system could be a renal ultrasound. A voiding cystourethrogram is an x-ray of the lower urinary tract where dye is inserted into the lower urinary tract via a Foley catheter. So the child comes in for this test, a Foley catheter is placed, dye infused, and x-ray is taken. An IV pyelogram sort of addresses the other end, and that's an x-ray of the kidneys with the injection of intravenous contrast dye. If this is a facility with nuclear med testing abilities, they may do a DMSA scan, which is a nuclear study. More commonly, though, you're going to see ultrasound and x-ray. Urinary tract infections. So urinary tract infections are one of the most common conditions of childhood, and it's often impossible to localize the infection. So it can be very challenging to figure out, did this infection start in the bladder? Did it start higher up in the kidney? Often by the time it's diagnosed, the entire urinary tract is being affected. There is a higher incidence of infection among uncircumcised boys younger than 3 months old and in females younger than 12 months old. And both are associated with hygiene issues. And with the young females in particular, it's due to their anatomically having a short urethra. So this is a teaching opportunity for parents to be changing diapers when wet, to not be letting their infants sit in a wet diaper, and also to be doing peri-care with all of their wet diaper changes. A new onset of recurrent UTIs of unknown etiology may be an indicator of neglect or abuse, but not always. It is just something to keep in mind. So some terminology for UTIs that you may see in a pediatric practice, as well as in adult practice, because we know UTIs are fairly prevalent among older adults as well. Bacteriuria is the presence of bacteria in the urine. So asymptomatic bacteriuria may not need treatment. Symptomatic bacteriuria needs treated. Pyuria is the presence of pus in the urine that would need treated. Recurrent UTIs are UTIs that keep coming back. A persistent UTI is a UTI that is not getting better on antibiotics. Cystitis is a UTI that's where the symptoms and site of infection are localized to just the bladder. Urethritis is a UTI, where the symptoms and infection are localized to just the urethra. Usually this would be in the case of males, since they actually do have that longer urethra where it could potentially just localize. Pyelonephritis is a confirmed infection of the kidneys. And then urosepsis is when a UTI, the infection is releasing toxins that affect the other body's systems as well. And you know this happens with all types of sepsis. So there are a variety of organisms that can cause UTIs. Most commonly, it's going to be E. coli. Approximately 80% of UTIs are from E. coli. And this again is a hygiene issue because E. coli is found naturally in stool. So E. coli doesn't belong in the urinary tract, but if we find E. coli in the urinary tract, which we often do, we can presume that this is from a hygiene issue. Some of the other microorganisms that have been known to cause UTIs commonly: Proteus, Pseudomonas, Klebsiella, Staph aureus, Haemophilus, and Staph. UTIs cause an altered chemistry of the urine and bladder. Normally, we have mechanical and chemical characteristics to protect the urinary tract from being colonized by bacteria. This has to do with mechanically the fact that we void outward, and chemically that urine is normally acidic and inhospitable to bacteria. Anytime we change any of these factors, the body is opened to a higher risk of UTIs. So in the case of children who have vesicoureteral reflux, the sphincters that should be only allowing urine to pass outward are actually refluxing and allowing urine to flow backwards and allowing bacteria in. And that's a condition that the voiding cystourethrogram with the dye through the Foley would diagnose. Increased fluid intake also decreases the organisms present and flushes them out. So when we're seeing UTI, oftentimes we're seeing accompanying dehydration and that the urine is not as acidic as it would normally be. Cranberry juice has not been found to be effective in preventing or treating UTIs in actual studies that quantify the data. However, anecdotally, many patients do report positive symptom alleviation. So while it's not a cure, it may be an aid to help alleviate symptoms during treatment. So any child who exhibits any of the following symptoms should be evaluated for a possible UTI: incontinence, urinary incontinence in a toilet-trained child, strong or foul-smelling urine, urinary frequency or urgency, pain with urination, and that pain can be urethral, so it could be described as their private is burning, it could be suprapubic, it could manifest as lower abdominal pain, or it could be in the flank over the kidney area, so pain in their side or back. Symptoms in infants are more insidious because they're not able to tell us what they're feeling. So some signs to be on the watch out for would be vomiting, poor feeding, fever, irritability, and external genital irritation. Fever of unknown origin in infants always triggers a differential diagnosis workup to try and find the site of infection, and a sterile urinalysis, either by a straight catheter or by a suprapubic needle bladder tap, is always indicated for these infants to rule out. So when we're diagnosing urinary tract infection, this is usually diagnosed through the urine specimen. And the test that we do, in addition to the urinalysis to detect the presence of bacteria, we will do the culture and sensitivity. This is to determine which microorganism is causing it and to which antibiotics they will be responsive. It's preferred that this is a sterile specimen. So as I mentioned, straight cath or a suprapubic needle bladder aspiration. If some of you may have seen the little adhesive bags that they can kind of stick a baggie onto an infant's suprapubic area, either around the male genitalia or over top of the female vulva. That is not a very worthwhile specimen at all if you're talking about ruling out a UTI. The reason being is because there's going to be bacteria from their skin in there, no matter how well you clean. So you're not really going to be able to diagnose a UTI at all from that type of specimen. That type of specimen is only useful if you're looking for other things other than confirmation of a UTI. Other types of diagnostics that may be done in the case of UTI would be percutaneous kidney tap, imaging, or the DMSA scan. But more often than not, the urine sample is going to provide us with the information we need to know. So here's the different examples of ways you could obtain urine. So there's the U-bag, that's not sterile. There's the little infant straight cath kit, that would be a sterile procedure. And then the suprapubic bladder tap, that would be done by the physician or mid-level provider if they're trained. So for treatment of UTIs, going to eliminate the infection, and the most common effective antibiotics for pediatric UTI are penicillins, cephalosporins, sulfas such as Bactrim, and nitrofurantoin, which is macrobid. And you will see occasionally children who have chronic recurrent UTIs on a daily dose of macrobid. Occasionally they will do that for some time until the UTIs have been well controlled. We want to identify contributing factors and reduce the risk of occurrence. So if it's a hygiene issue, if it's an abuse issue, if it's an anatomic defect with the ureteral sphincters, we want to prevent systemic spread of infection. So we want to treat it early before it turns into a sepsis. And we want to preserve renal function and prevent acute or chronic kidney damage. The most important goal is prevention. So when we talk about hygiene, we're talking about, again, changing infants as soon as they're wet or soiled. For the females, wiping front to back. Cleansing the genitalia daily with a mild, unperfumed soap. No tub soaks or bubble bath. We want children to void as soon as the urge is felt and not encouraged to hold it. And then for those who are sexually active, perhaps our adolescents, teaching them to urinate and do pericare after intercourse. Keeping well hydrated is important, flushing that bacteria through. Wearing breathable cotton underwear makes a less hospitable environment to bacterial colonization. And seeking care as soon as symptoms first appear so that the infection does not progress and spread. So I mentioned earlier about the vesicoureteral reflux. This is the retrograde flow of urine from bladder to the upper urinary tract. And this is related to anatomical abnormalities. Typically, that would be the primary reflux. Secondary reflux is sometimes seen related to an acquired condition, could potentially untreated UTIs causing scarring in this area. It's diagnosed by the VCUG, the voiding cystoureterogram, and it is the most common cause for pyelonephritis in children. So we do prevention with a daily macrobid, and corrective surgery may be indicated. Obstructive uropathy is a condition involving structural or functional abnormalities that are obstructing normal flow of urine. And hydronephrosis is the name for fluid engorgement of the kidneys, and that happens because of a backup of urine above the obstruction point. This condition can be congenital, it can be one-sided or bilateral, and it can be a total obstruction or an incomplete partial obstruction. Early diagnosis and surgical correction are essential to prevent recurrent kidney infections. Postoperatively, these kiddos will have a urostomy drainage. Here's a little illustration of what may be happening in an obstructive uropathy situation. So you can see that our right, or patient's left, kidney is engorged with the hydronephrosis compared to the other side. Elimination problems, enuresis, that is the intentional or involuntary nighttime bedwetting. To be diagnosed as actual enuresis, it needs to occur twice a week for at least 3 months in a child who's at least 5 years old. And it cannot be related to a medication or a medical condition. So organic causes need ruled out. So first thing we're going to look for is UTI. If we're not able to identify an organic cause, there are a couple different approaches that can be used to treat this, and a multimodal approach is going to be most effective. So this may involve restricting fluids at night, cutting off a certain time for PO fluids, waking the child at regular intervals to void. Enuresis alarms, similar to a bed alarm pad, it wakes a child up when they've wet the bed. And then for more severe cases, we can do medications. There's an antidiuretic called desmopressin. Tricyclic antidepressants sometimes help, and antispasmodics such as oxybutynin may be effective as well. I would remember the desmopressin because that is what is most commonly used for this, and you may be seeing that again. Care management with enuresis is going to involve support to parents and children, teaching the parents to support the child's efforts and not be overly critical or shaming of them. Monitoring and treating constipation, because this is found to have an effect as well. Maintaining positivity, not punishing the child for their accidents, closely observing medications for side effects, and then it's actually best to avoid diapering at night. So I know that a lot of times for the older children that have bedwetting, parents will put on the pull-ups. That's okay occasionally, such as for an overnight stay in the hospital where they're going to be getting a lot of IV fluids. But at home, that's not going to help the problem. That's actually going to prolong it. External defects of the external genitourinary tract can be anywhere from minor to major. Major ones are going to require surgical repair, and the older the child is, the greater the risk for psychological related to genital surgery. So just a few of these conditions that may require surgery is phimosis. Phimosis is a narrowing of the opening of the foreskin. It's a normal finding in newborn males that usually resolves without intervention. However, if the foreskin does not open itself up, it can lead to problems. Some of those problems can be dribbling urine patterns, so ineffective voiding. Ballantitis is an inflammation and infection of that tight foreskin. Some of these cases can be managed with steroid cream and gentle manual retraction. However, we will educate the parents to not force it back so as to not cause actual trauma and tearing. If retraction is forced back and they're not able to pull the foreskin back down, this is called a paraphimosis, and it's considered a surgical emergency because circulation and blood flow can be cut off to the exposed tip then. Some cases that are not responsive to the steroid cream and hygiene practices may need surgery with a circumcision. Here we have some images to show you the phimosis, the paraphimosis, and the ballantitis. Hydrocele is fluid trapped in the scrotum, and this can be a communicating hydrocele, which means fluid is leaking in from the peritoneal cavity, or it can be non-communicating with the peritoneum, meaning there's another cause of this fluid buildup. In infants, this is often resolved by 12 months old without intervention. In severe cases, or cases that do not resolve on their own, it's going to require outpatient surgery. After the surgery, there will be temporary swelling and discoloration. The child should be instructed to avoid straddle toys, such as rocking horses or bikes, for 2 to 4 weeks, and the child will be allowed to bathe in about 3 days. Here we have an illustration of hydrocele for you. Cryptorchidism is failure of one or both testes to descend, and the testes can be in the abdomen, canicular, or ectopic. Anorchism is the total absence of any testicles, and genetic testing would definitely be indicated for those cases. But in the case of your standard undescended testes, there are varied contributing factors. It is diagnosed by non-palpable testes during the routine physical exam of the infant. We want to make sure that the room is warm and that the hands are warm, because there is a phenomenon called the cremasteric reflex that causes the testes to naturally pull up and hide and be more difficult to palpate. Once it's confirmed that the testes truly are undescended, surgical management to position them downward will be required. The main risk of operation is postoperative infection. Occasionally, this can affect fertility, and those would be times when genetic testing would also be indicated. And here we have an illustration for the different locations of the undescended testes. Hypospadias is a congenital anomaly of urethra opening on the underside of the penis. It can be anywhere from mild to severe. The more severe would be a urethral opening near the scrotum. Surgical correction is needed to enhance voiding, to improve physical appearance, and preserve sexual function, and this is typically done between 6 and 12 months old. On these infants, we would avoid circumcision, and a cath may be needed temporarily postoperatively. There's an illustration for you for the different types of hypospadias that may be seen. Extrophy epispadias complex is a set of severe defects involving musculoskeletal, urinary, reproductive, and intestinal tracts. So the epispadias is an exposed or open underside of the urethra. The bladder extrophy is an open inside-out bladder, and the cloacal extrophy is a bladder extrophy and intestinal extrophy. And this results from the abdominal wall and other structures not fusing. And here we have an illustration for you of what that would look like. This is a very severe case. Tissue ulcerations and infection are likely. So for that infant, you would want to keep that covered with sterile moist gauze. Renal damage will occur if it's left untreated. It may include other genital malformations as well. And the surgeries are done in stages. The primary goals of surgery are going to be to preserve renal function, to gain urinary control, to prevent UTIs, to preserve continence and sexual function, and to restore physical appearance. So care management, again, limiting trauma to the exposed structures with sterile moist saline gauze, monitoring urinary output, monitoring for signs of infection, pain management, immobilizing that area, wound care, caths will likely be needed, and support of the parents. Disorders of sex development. Sometimes this manifests as infants born with a discrepancy between their external genitalia. So this could be ambiguous genitalia, where the external structures are neither apparently male or female, or this could be discordant genitalia, where the external genitalia does not match the internal sex organs and or does not match the sex chromosomes, the X and Y chromosomes. When this occurs, it's often caused by androgens, testosterone deficiency or excess. It may be a chromosomal abnormality, or sometimes we can't figure out why it happened. So therapeutic management for a sex development disorder, we're going to address firstly their urinary function, monitor electrolytes for signs of adrenal insufficiency. Ultrasounds are indicated to determine what type of internal sex organs they have. Lab testing for their chromosomal karyotype to figure out genetically X and Y, are they male or female? And then corrective surgery in lieu of all these factors. So years ago, they would sometimes leave it up to the parents. Do you want this infant to be male, corrected to male, or corrected to female? Or it would be up to the doctor which procedure is going to be easiest given this tissue formation. Is it going to be easier to form this into a penis or into a vagina? And that, as you can imagine, led to a lot of problems for those individuals, for those patients who on the inside were a certain gender, but on the outside had a different set of parts determined by their parents or a doctor who had not done a thorough investigation. Thankfully, nowadays, we're more conscientious in this. There can be psychological problems related to the genital surgery. This can be in the immediate phase or later down the line at the time of puberty. So this ranges anywhere from body image concerns to parental anxiety, sexual body image, surgery and separation from parents. Care management is going to involve preparation for procedures. Tub baths will be discouraged for a time since it is a genital surgery. Keeping the site clean and monitoring for infection and support groups. Nephrotic syndrome. Nephrotic syndrome is a clinical state characterized by massive protein loss due to glomerular damage. So massive protein loss, so there's going to be protein in the urine, there's going to be proteinuria, there's going to be a drop in the serum, the blood protein levels, so that's hypoalbuminemia, low albumin levels. Albumin is our blood protein measurement. Hyperlipidemia, so lipid levels are going to be elevated because the liver is attempting to compensate for the body's protein loss. And there's going to be edema in the peripheral tissues. So here's a cascade of what happens with glomerular damage. There's glomerular damage. There's massive protein loss through the glomerulus into the urine. There's decreased protein levels circulating in the blood, which causes the liver to increase its synthesis of proteins in the form of lipids. In the meantime, because of the protein loss, it creates this sort of hypotonic state, which causes a decreased oncotic pressure, which causes edema in the peripheral tissues and a circulatory hypovolemia. So what causes this nephrotic syndrome? Well, primary means there's no known cause. So that could be called idiopathic nephrosis, childhood nephrosis, or minimal nephrotic syndrome for the more mild types. Typically, though, we're seeing this in associations with conditions that are causing the glomerular damage, and that is referred to as secondary nephrotic syndrome. There is an autosomal recessive genetic disorder that causes a congenital nephrotic syndrome as well. So the damaged glomerular membrane is normally impermeable to large proteins, but because it's damaged and thinned out, it becomes permeable to proteins, in particular albumin, which is our major circulating blood protein. Albumin is lost in the urine, so there are elevated levels of protein, and specifically albumin protein in the urine, and then the serum, our blood circulatory albumin levels decrease. This causes fluid shifts from the plasma into the interstitial spaces. Diagnosis of nephrotic syndrome is based on clinical manifestations. So typically we're going to have a history of steady weight gain with loss of appetite. So the child does not feel like eating or drinking much, but they're still retaining a lot of fluid. There's going to be massive proteinuria on urinalysis. Here's the tricky part. Their glomerular filtration rate may read as normal or high. So remember, it's not that the glomerular membrane doesn't filter anymore. It's that it's letting those large protein particles through, whereas it should not be. Serum protein and albumin will be low. Serum sodium will be low because sodium follows other electrolytes and fluid. Platelets may be elevated. Hemoglobin and hematocrit may be normal or elevated due to that dilutional effect. And then a kidney biopsy will definitively confirm this diagnosis if the rest of the clinical picture is leaving it somewhat unclear. However, kidney biopsy is not necessary to diagnose nephrotic syndrome. If the rest of the clinical picture lines up, we can diagnose it without the kidney biopsy. Management of nephrotic syndrome is going to be supportive care. We're going to administer diuretics to reduce fluid retention in the tissues. We're going to prevent infection. Immunosuppressive corticosteroids often help, and we want to mainly minimize complications from this condition while it's happening. Prognosis of nephrotic syndrome is generally good. Early detection and treatment decreases chances of relapse and will maintain renal function. So our quality patient outcomes, what we're looking for on discharge are protein-free urine, that we were able to prevent them from getting any acute infections while this was going on, that edema, peripheral edema is now absent or minimal, that they maintain their nutrition and were able to get enough protein in their bodies, and that metabolic abnormalities are controlled. So your acute care management for the child with nephrotic syndrome is going to include strict intake and output, daily weight measurements, sending urine samples daily for albumin checks, checking their abdominal girth measurement for ascites edema, that's your peripheral edema in the abdomen, vital signs, monitoring for signs of infection, monitoring their appetite levels, encouraging a high protein diet, salt restriction, and fluid restriction. And those are things you'll want to remember because we're having this fluid shift into the extravascular space. We want to maintain control of that edema. So in addition to administering diuretics, we are going to limit both salt and fluids. So you'll want to remember that with nephrotic syndrome. Activity adjustment may be needed, and then family support, teaching, and arrangement for follow-up. Acute glomerular nephritis can occur as a primary event, but more typically it's a manifestation of another disorder. And most commonly it will occur after an acute strep infection. It has a latent period of 10 to 21 days. So we may have a child who had a strep throat infection and then 2 to 3 weeks later develops this. Occasionally it does occur on its own as an immune complex disease. So what happens with the glomerular nephritis? There will be a decreased urine output. There will be fluid retention causing edema and elevated blood pressure. And with this condition, they're retaining fluid in both the intravascular and tissue spaces. There will be blood in the urine. So that's important to remember the difference. You're not going to see blood in the urine or elevated blood pressure with nephrotic syndrome. You will see that with glomerulonephritis because there is bleeding in the upper urinary tract. There is going to be protein in the urine, and the amount of protein that's found in the urine is an indicator of the severity of the condition. So for diagnosis of glomerulonephritis, the provider is going to assess for a history of a strep infection or cold symptoms. We can do a blood test for strep antibodies to see if there was a recent strep infection. The urinalysis will show both protein and blood, and there will be elevated BUN and creatinine levels. So that is different from nephrotic syndrome as well. You will see elevated BUN and creatinine with acute glomerulonephritis. X-rays are indicated, chest X-rays, to rule out cardiac enlargement or pleural effusion. And renal biopsy is sometimes done as well. The therapeutic management of acute glomerulonephritis, we're going to manage edema through daily weight measurements, accurate intake and output, daily abdominal girth measurements. Nutrition, again, we're going to have low sodium and fluid restriction diet. Prevention of infections. Diuretics are more important for nephrotic syndrome, but because we're having retained fluid in both the intravascular and extravascular space in acute glomerulonephritis, the priority here is going to be the management of the high blood pressure. And this is best done with ACE inhibitors. We're going to monitor for neurocomplications from cerebral edema, such as seizures, and these children should be on seizure precautions. Seizure precautions, in case anyone doesn't know, involves patting the side rails and not having anything with them in the bed that could be dangerous should a seizure occur. Almost all children with post-strep glomerulonephritis recover completely. The prognosis is a little more mixed if it's from other causes. Generally speaking, subsequent recurrences of this are uncommon. It's usually a one-time illness. However, some children have been reported to develop it as a chronic disease. Hemolytic uremic syndrome is an uncommon acute renal disease that occurs in infants and small children. It's thought to be related to bacterial toxins. The symptoms are hemolytic anemia, so drop in red blood cell count, drop in H&H, thrombocytopenia, which is low platelets, renal injury, so elevated BU and creatinine, and neuro symptoms. So what's happening here is that the endothelial lining of glomerular arterioles become swollen and occluded, and they are basically crushing red blood cells as they pass through these tight spaces. And these crushed and damaged red blood cells are removed by the spleen, so we have lower amount of circulating red blood cells. So this is going to manifest itself as anemia, low red blood cells, low platelets, and renal failure. The therapeutic management is supportive care and dialysis if needed. Prognosis with hemolytic uremic syndrome is good. The recovery rate is approximately 95%, but it does require an interprofessional care management team. If it becomes a chronic disease, they may need management of that, and supportive parents is going to be crucial through this as well as with the others. We're just going to talk about general renal failure now. So renal failure is defined as the inability of the kidney to excrete waste, to concentrate urine, and to conserve electrolytes. Renal failure can be acute with a sudden onset or chronic with a slow gradual onset. Azotemia is the term for the accumulation of waste in the blood. It's nitrogenous waste, so this is going to manifest itself as an elevated creatinine level. Uremia are the manifestation of toxic symptoms due to the retention of these wastes. So acute kidney injury is the sudden inability to regulate volume and composition of urine. It's going to manifest itself with oliguria, so decreased urine output, azotemia, metabolic acidosis, and electrolyte disturbances. There will be poor renal perfusion, there may be urinary tract obstruction, and acute renal damage occurs, and this is often precipitated by severe illness, surgery, or trauma. So with our acute kidney injury or acute renal failure, the acute is usually reversible. It usually begins with a decreased urine output, and then as the body is turning the corner, there will be a natural diuresis that occurs with a high urine output, and then finally level back down into normal. Patient may be critically ill during the acute phase and will require close monitoring of labs. Therapeutic management involves treatment of underlying cause, management of complications, and supportive therapy. Complications of acute renal failure include water intoxication and hyponatremia, which causes seizures, elevated potassium hyperkalemia, causing cardiac arrhythmia or cardiac arrest, hypertension, anemia, seizures, hypervolemia, so edema, hypertension, or cardiac failure from pulmonary edema. The prognosis of acute kidney injury depends on the severity of the cause. They may recover completely, or there may be residual renal impairment with hypertension, and these kiddos may be hypertensive and on ACE inhibitors for the rest of their lives. During the acute phase, our care management is going to involve maintaining I's and O's, monitoring vital signs. These kiddos are usually going to be a PICU level of care. We're going to assess their nutritional needs for their protein, monitor for complications, and remember that family support. Chronic kidney disease is defined as more than 50% of the functional renal capacity being destroyed. The destroyed diseased kidneys can no longer maintain normal chemical structure of the body fluids. This is a progressive deterioration over months or years, and clinically there's going to be uremia. So that azotemia is the buildup of nitrogenous wastes, and they're going to have symptoms from that. That's our uremia. Potential causes of chronic kidney disease include congenital renal and urinary tract malformations, unmanaged vesicoureteral reflux associated with recurrent UTIs. It may be a hereditary disorder, chronic pyelonephritis, chronic glomerulonephritis. There's a cause called anaphylactic purpura, which is a capillary inflammation following a bacterial or viral infection, or lupus, which would be an autoimmune cause. So pathophysiology, what's happening is that increasing numbers of nephrons are becoming totally destroyed, and more nephrons are becoming damaged so that few normal nephrons remain, and the kidneys are no longer able to maintain fluid and electrolyte balance or effectively remove nitrogenous wastes from the blood. Management includes diagnostic eval and monitoring with labs. Therapeutic management is going to promote maximal renal function. So we will do our best to maintain fluid and electrolyte balance, treat systemic complications, and promote as normal and active a life as possible. The only treatments are dialysis and kidney transplant. So when we're talking about a child on dialysis, we're really thinking about maximizing quality of life. Post-transplant complications also have an effect on their state of health and quality of life moving forward. For care management, we're going to manage each complication as they come. There's often going to be a lot of procedures and hospitalizations associated with this. Diet therapy is difficult to maintain, and adolescents tend to rebel against these regimens. It's hard for a kid. Dialysis is a source of stress. Dialysis is the process of separating colloid and crystalline substances through a semi-permeable membrane. So basically, we are mechanically doing what the kidneys should be doing. There are a couple different methods. There's peritoneal dialysis, hemodialysis, and hemofiltration. So I will post these links in the comments so that you can see demos of these procedures. So peritoneal dialysis is the preferred method of dialysis for children because it can be done at home. So the abdominal cavity acts as a semi-permeable membrane for filtration. So warm solution is infused into the peritoneal cavity by gravity, remains for a period of time, and then is manually drained off. Hemodialysis requires special vascular access, and the equipment is not available for in-home use. So this can only be done on children who can be brought to the dialysis facility 3 times a week and each session lasts 4 to 6 hours. It does achieve rapid correction of fluid and electrolyte abnormalities faster than peritoneal dialysis does. Kidney transplant, the blood types must be in a match, and often this can be provided from a living donor, such as a parent or a sibling, or it may be from a cadaver donor. The primary goal is long-term survival of the grafted tissue, and long-term immunosuppressant therapy is essential to prevent rejection. So transplant recipients will be on an immunosuppressant cocktail for the rest of their lives. This causes them to have an increased risk of infections, and rejection can still occur.